Hello again, I'm Professor Béatrice Cochener.
And I'm Dr. Pooja Khamar. Welcome back to the second part of a three-part independent medical education video interviews series on refractive surgery.
So today we're looking at something every surgeon has encountered, which is the post-operative surprises. But many of those surprises begin before we even touch the eye.
Yes, and we'll explore how the ocular surface like dry eye, MGD, Demodex or Blepharitis can affect measurements and how a proactive workflow can help with the surgical precision. Here's telling a result from the 2024 ESCRS clinical survey data. What percentage of refractive surgery in your practice do experience dry eye before and after the procedure? So if you just look here, you can actually make out that if you do a laser vision correction, which is LASIK procedure, compared to that of an intrastromal lenticle extraction, which are the KLEX procedures. If you see the incidence, it's always higher on the LASIK side compared to that of the lenticule side. What do you think about it?
I think first that it's the case only for the post-operative period within the next 6 months. Then after, these differences just decrease.
Yes.
And it's actually related to the wound healing. When you got a dry eye before the surgery, of course that will get an impact for the recovery then after.
Dry eye is not just itching or irritation, it can also impact your surgical outcomes. So even if you do like a perfect surgery, if you're dry eye before, then post-operatively, it can also lead to a refractive surprise because your epithelium doesn't heal well, and if your epithelium doesn't heal well, it may just come across as a pseudo-regression. And also if again the epithelium is irregular or the wound healing is not proper, then you may have glare, halos, many other complications.
If you have, a rupture of your tear film, you can go, to big error in the measurement, the topography assessment, the measurement of the cylinder. So it's all about the target. In your hands, what are the key values that we should measure before?
A meibomian gland expression on a slit lamp, or looking at how the tear film looks, whether it's healthy or not, or the tear film height itself, or if you're not performing the surgery same day, which we do not recommend, you can also do a tear film breakup time. If you just do the simple tests like the tear film breakup time, expression of the meibomian glands, or just pressing them to see how the quality of the meibum is, or the tear film height, I think it can give you a lot more information than the expensive instruments what you would look at. So, and of course, diagnosing is the only first step. We also have to act on what we find, even when it means delaying the surgery. So what do you think about it?
First, most of them will be upset. It's quite difficult sometimes to convince them. But definitely I would put them under some good lubricant treatment. When I say good, it's maybe a combination of hyaluronic acid and maybe Trellos. I will check them 2 or 4 weeks later, and normally, if it's good enough, I should consider them if whatever LASIK, KLEX or PRK.
Is there a time you would like to start a cyclosporin drop for them?
Cyclosporins to me is already a big tool for severe dryness. So if I had to go in that direction, for sure they won't be candidates for KLEX or LASIK. Potentially PRK, certainly more a fake EKIOL if we have to deal with that. In that regard, we must say that the meibography is quite useful because you show them the pictures and they are understanding on a better way what that means, as we can show them different kind of topography and you say you've seen the colors are completely different. It's related to your tear film. They are again more active and less skeptical on what we are trying to promote.
If you probably ask your patient to delay a surgery, ask them to do this extra step, they do become skeptical.
I prefer to lose a patient that is skeptical than a patient that is not convinced that I'm telling him the truth. So I need a patient as a partner.
That's amazing, and I think we should always remember this, that losing a patient or making a patient a partner in decision making is always more important than doing the wrong thing. So when it comes to surgical planning, what's one part of your ocular surface protocol that you would never skip?
Definitely the slit lamp, extended to the face, expression of the lids as you mentioned, and one drop well and properly used of fluorescein. That will be the key, and the stability of the topography. I think that it's all to feel safe in the assessment of our patient. Addressing the ocular surface before the surgery, it's just crucial. And so it should be part of our best practice recommendation and hopefully will come from the guidelines. So thank you for joining us for the second episode of the ESCRS Independent Medical Education video interview series on refractive surgery. See you for the third.